you. So I was just going to say to people that next month as well, we have a webinar in January on the 17th about the osteopathic lesion with Robert Cartwright. And then on the 12th of February, just as an introduction towards the conference that we have on the 1st of March, we have Melvin Wallman doing a webinar on talking about the pelvis. And just as a reminder, Tim will be in the conference of the ICO this year. He will be doing a workshop on the 2nd of March and a conference on the 1st of March. And we had just confirmed all the speakers. And we are very happy to announce that Dr. Eric Snyder from the Andrew Taylor Still University will be with us in London, running a workshop and the conference as well. And Christian Fossum, he will do a workshop and conference as well. And then Chris Batten will do an introduction workshop to classical osteopathy on Friday, the 28th of February, which is open to everybody as well. And also in the conference, we will have the Professor Dr. Maribel from Spain. She will do anatomy of the spine. So it will be a nice conference, 1 hour for every speaker, so plenty of time to chat about osteopathy and anatomy and neurology. So it will be a very nice weekend, I suppose. And that's my bit, Tim. I'll let you carry on with this super lecture. Very interesting.
Okay.
Thank you.
Well, I'll start with pressing the button and go on the play, and hopefully this will work. Okay, everybody. Thanks very much once again for joining me for part 2. I will briefly go over some aspects of what we've already done. We've looked at some aspects of the definitions of multiple sclerosis. We're looking specifically at this case study, which is relapsing remitting category of multiple sclerosis. And then what we're going to do today is have a look a little bit at the reviewing the case study, the profile and presenting symptoms and presentation of the patient case study. And then we're going to look at some aspects of evaluating treatment outcome, because this is quite often something that's very valuable to us nowadays, to actually kind of like give some kind of evidence or kind of like outcome measure in terms of the nature of our treatment or our treatment approach. I'm going to throw in a few existing osteopathic research papers, and then we're going to kind of like just zip over some additional considerations. And also there will be a situation where, well, I will be giving also later on to Diego as a resource, a link to some resource page that I'm going to put up for people regarding the content of this, and some research papers for reference use, of course, according to your and that you can look at it, provide it according to your internet provision for research documentation, etc. So let's carry on with this. And we've got about an hour, so I'm going to just start my timer if I can. Here we go, and continue with it if we can do. So one of the things that's interesting about this scenario is we're going to be looking at specific components of the respective presenting symptoms that we have. In this particular case study, we have kind of like this presentation where we have various factors that are typical in the pattern, but also in the presentation of MS. And we're going to look in addressing it in terms of the body systems and how we might actually kind of intervene on an osteopathic perspective. I'll just catch up with myself there. So we're going to be looking at various things addressing the GIT system, once again reviewing that, looking at the function of bladder, also ear, eyes, nose and throat, motoric function, and various other things that relate to that, including the effect of prolonged stress, cognitive and emotional well-being within the patient as well. So this kind of like has a cross systems kind of like approach to it. When I first did this presentation in 2016 in Berlin, I deliberately kind of like presented it in this way to kind of like look in terms of the unity or the unity perspective of our work, body unity, and then kind of like brought in within the context of the workshop the idea that we're actually implementing the many factors involved in the body adjustment within the context of the treatment of MS2. So that was nice. So let's continue with this. This is the kind of like scenario we're getting. We're getting this hemiparesis presentation with the patient with various aspects of spasms from time to time in the muscles, transient sensory loss in some parts of the arm, diaphragmatic weakness sometimes, and also prolonged periods of constipation, and of course changes in voiding function of the bladder, all associated with various autonomic changes relating to the presenting conditions that was there with this this type of relapsing remitting presentation in multiple sclerosis in the PET case study. So we're going to zip through this a little bit. So one of the things we're going to look at is, how are we actually going to kind of like interface within the context of our work in terms of the presenting symptoms that we're going to address. And of course, we're going to do that within the within our limits of our competence. We're not going to try to and safety. We're not going to go in too much and provide too much direct or indirect treatments that are going to provoke reaction. We're trying to do it within the confines of the tissue response we have, and of course within a dialogue with the patient too, in terms of our tissue field, but also in terms of just simple verbal dialogue as well. So one of the things we're looking into in terms of autonomic aspect is, the function of the autonomics in relation to the visual acuity, the relationship of various aspects of vision and ocular motor function. Of course, also ear, nose and throat, eye, ear, nose and throat drainage as well, parameters that are involved with that, and trying to reduce that sensitivity within the eye, specifically with that presenting neuritic or neuritis type of presentation that we get intermittently with this kind of case profile. So addressing the eye, quite often we can deal with this indirectly through the autonomic innervation from the thoracic region, as you see here in the diagram. I think this is extended in a further diagram later on. Let me just have a look at my notes that I'm having from parallel to here. Yeah, you'll see that later on. But then you see that there's obviously we have our upper thoracic innervation in terms of the innervation from the sympathetic ganglia there, and also the respective ganglion in relationship to the optic function and the ciliary ganglion, etc., in the eyes. So let's have a look at this. We can look at this in a little bit more detail. We have a long ciliary nerve. We have various components within the autonomic nervous system that is specifically dealing with both vascularization to the head, the brainstem, but also the ophthalmic centers, but also specifically in relationship to the associated ganglia that innervate the eye too. So this can be explained in a little bit more detail. This long ciliary nerve, sympathetic, and of course we have the short ciliary nerve, which is combined sympathetic and parasympathetic. So again, we have this effect both on the visual acuity, the effect of the vascularization to the eyeball, and also the actual function of the eye itself. So dilatory pupil function, motoric function, etc. So when we consider that, we can work within the upper thoracic spine, for example, to implement some indirect relationship to the eye. But we can also work in relationship to the oculi muscle groups and actually work with gentle lymphatic drainage around the periorbital lymphatic tissues as well, to try and encourage relaxation within the domain of the orbit of the eye, but also within respect to drainage and also tear duct drainage as well. And, try to reduce the sensitivity that we have typically with that muscular and ocular effect of the neuropathy that we have, the inflammatory response that we quite often get in the optic canal as well. So here we have all these wonderful illustrations from our resource here, and you can see the complexity that we have in terms of the origins of the specific autonomic nerves themselves and how they kind of like relate to the respective anastomotic branches in the respective ganglion that all kind of innervate the vascularization of the tissues around the eye and the orbit, but also specifically in terms of the papillary function, etc. So, these are all components that we can have gently some kind of influence on, both indirectly through upper thoracic involvement, also in relationship perhaps to the vascular circulation to the brain, the medulla, for example, and also the effective nuclei from which these specific ganglion have their innervation. And the nerves have the orbital muscle groups have their innervation too, which you can see quite nicely on that illustration there. So going on from that, let's have a look at the nature of our approach to treatment. We can work very superficially on the actual orbits of the eye, gentle orbit mobilization perhaps, or periorbital drainage and relaxation. So there's quite a few nice procedures that we can do. And of course, we can deal with various superficial branches of the specific nerves that supply the face, trigeminal and ophthalmic branches of the trigeminal, for example. And of course, the actual gentle component of the lymphatic tissues around the periorbital structures as well. So in relationship to the ciliary ganglion too. So that is like a mechanico-transductive effect that we have on the orbit and the surrounding tissues. So if I just zoom in here, you should better see a little bit more detail as to the actual superficial structures that we can begin to interface with within the context of our digital drainage of the orbital tissues and the respective rami that relate to the respective branches of both trigeminal and facial nerve innervation to the face, etc. Remembering that there's a sensory afferent aspect of this too. So what we're actually doing on the tissues are going back through the sensory afferent nerves of those respective vagal specific facial nerves and trigeminal nerves, and having a specific effect on their anastomosing branches in the brainstem and corresponding physiological effect, for example, through the trigeminal and vagal connectivity there. So, through our work, through relaxing the eyes, relaxing the face, relaxing the forehead, etc., we begin to interface with other ganglionic groups that are particularly going to have an influence on vagal tone, for example, and change the autonomic response in terms of that too. So whatever we're doing on the head, the face, is specifically significant in our work in terms of dealing with mediating autonomic balance, for example. So let's continue from that. One of the things that are very significant in relationship to our work is the relationship of our lymphatic influence, and there is a specific indication that once we start working with the dynamics and lymphatic system, we're also dealing with the neurolymphatic vascular component of beginning to address some components of the associated condition relating to multiple sclerosis. So this is interesting when you look at this particular article, they're looking at lymphavascular drain interstitial fluids, which contain tissues and waste products. So we're looking more at the component of the essential lymphatic vasculature, and also the essential changes in the dynamics of intracranial lymphatic functionality too. And as we know recently, there's been a lot of interest in the lymphatic system. So we're going to look into that in terms of one parameter that we can effectively have an influence on too. As soon as we start beginning to interface with that lymphatic system, we're beginning to change the effective accumulation of intracranial neurotoxin effects to an amyloid accumulation. And this particularly has an influence in kind of creating a flushing and a drainage of the intracranial structures. So if you look at that particular slide there, it's quite interesting how this whole scenario of meningeal lymphatic network drainage is something that we're beginning to kind of like become more familiar with, and in the context of how we can kind of like facilitate almost the detoxification process within the cranium itself, in terms of the corresponding neurolymphatic vascular anastomoting structures within the cranium too. So this is what we're looking at, and this is effectively what we can also kind of influence through various mechanisms of our treatment approach. So continuing from that, we'll see here that we have a specific relationship that we can start to interface with in terms of the lymphatic clearance, and of course the relationship of the blood-brain barrier transport within the cranium, And this becomes very significant because there is a correlation between lymphatic and blood-brain barrier functionality, and both are thought to be involved with the actual elimination and drainage of the cranial structures and vascular structures. And they work in hand, and through our modality of treatment, through our ear, nose, and throat drainage protocols or approaches, and within our cranial dynamics of treatment, we can begin to facilitate this. So I want to try and bring this up also within the context of various other things that are very significant, specifically in relationship to the drainage system within the cranium. And also, the effect of, let's go back there, the potential involvement of meningeal lymphatic route in the central nervous system and the autoimmune response. So this is just another article that relates to this. Studies suggest that cervical lymph nodes house macromolecules that are drained from the CNS through the different pathways, namely the lymphatic network, associated with the nasal mucosa, cribriform plate route, and the recently characteristic meningeal lymphatic route, green arrow. So this is kind of like, this is tests done in mice and relating to the structures within the studies that they've done. This kind of like correlates and overlaps with what we're doing. So within the contents of our work within the frontal structures of the cranium, also the cribriform structures, and the relationship of the actual lymphatic drainage within the cervical lymph nodes, we're beginning to potentially have an effect on this meningeal lymphatic route and the influence we can have on potential drainage and the immune system. So, for example, the cervical lymph nodes, along with the lungs, are closely involved in immune cell traffic and honing into CNS grey arrows and autoimmune diseases such as multiple sclerosis, potato generation on the capillary immune cells. So, we're beginning to potentially, interface with this mechanism, and it's nice to kind of like be aware of these particular research papers that kind of like endorse or give an indication of the potential mechanisms that are involved with what we're doing with in terms of autoimmune mediation, and how we can have an influence on those particular drainage systems in the context of our treatment too. So this might be seem to be a little bit kind of like simplistic, but there is a very interesting correlation between the neuro endocrine and autonomic and immune system relating and connecting with each other within the context of our work as well, in terms of MS and other immune-related, autoimmune-related conditions that we find. So this becomes interesting because this is something that has become very, very, very recently researched and looked into in terms of the potential that we have in terms of this connectivity between venous drainage, between the choroidal plexus functionality, and this continuum of specific of related drainage pathways that we can kind of like tap into within the context of our treatment. So this is something that's is very valuable within one parameter of our treatment of MS, and quite frequently within the treatment approach, the cranium is not excluded, and of course the ear, nose, and throat, and ventral and anterior portion of the neck in relationship with the lungs, etc., is also very significant. So our whole lymphatic drainage procedure in our treatment, is significant too. So again, going from there, lymphatic continuum, opportunities of osteopathic manipulative medicine. So we're looking at encouraging this lymphatic system to encourage drainage. The lymphatic system is more active at night time, so if we can provide an environment where the patient is more relaxed during sleep and has more prolonged sleep, then again we're facilitating the mechanism of lymphatic drainage, but also through the mechanism of providing freedom within the upper thoracic region and the anterior thoracic region and the lymphatic drainage system itself. We're kind of like facilitating that mechanism too, and this is effectively what we're doing within our lymphatic and EE, ear, nose, and throat applications within an osteopathic treatment. Okay, so this is a kind of like protocol or an approach, which is from, again, the same resource. And it shows you how there are specific types of approaches within the context of treatment that we can give. The thoracic inlet-outlet relationship. We can do vertex or V-spread, occipital structure and jugular foramen influence. All these structures that we're specifically having an effect on within the context of our cranial work, within the context of our drainage on the lateral aspect of the sympathetics chain, and of course our ventral portion of the neck, as I discovered before. So, this is exciting for us because as osteopaths, we can begin to facilitate that natural detoxification within the cranium in terms of buildup of amyloid structures and, other consequent neurotoxic accumulation. There's components going on. So that can potentiate the reduction of symptoms as well over time. So this is something I'm interested in to see, what particular markers and what particular outcome measures we can start to study to see how, the treatment has, the effect of the treatment has become over time. So let's continue from this. So this is, an example here of typical ventral treatment approach, which, it actually kind of like integrates this approach, dealing with both the infrahyoid structures, the relationship of lymphatic relationship of the sternocleidomastoid, also the relationship of the fascia, substance fascia, and of course the whole drainage of the head and face too. So here are a few examples of various kind of modalities that a lot of us are familiar with that can facilitate this whole mechanism, including facilitation of the lymphatic system as well. And again, this continues through into the cranium in terms of the relationship with the orbit of the eye, various structures of the sagittal suture, springing, parietal lifting, various frontal lifting, and various superficial tissue mechanisms that we can apply within the context of our typical cranial or craniofacial, but also fascial to some degree, components of our treatment too, because we're not just focusing on the cranium, but also within the actual drainage mechanisms of the lymphatics systemically as well. So again, let's have a consideration of other parameters. We're also dealing with trying to coordinate autonomic function in relation to lung function, to lung excursion that ties in with the lymphatic drainage as well. And we have this scenario when there is kind of like reduced capacity within the lung, compliance of lung function, predisposing to the potential of infection, and also, the potential of changes in lung excursion and diaphragmatic function as well. So all these parameters are very significant, and within the context of treatment, we want to address this as well. So one of the mechanisms that we're looking at is what are the autonomic innervations to the lung? What is the functionality of the lung in relationship to the phrenic nerve, the functionality of the autonomic nervous system in terms of the function of the bronchial function itself, and of course the vascular supply, and of course the intercostal functionality too. So there's a lot of parameters that we can start to influence through the mechanisms that the application approaches that we use from day to day in our osteopathic treatment. So let's look at that. One of the things we can do is, again, begin to work with the trachea, hyoid, reduce the relationship of the carotid sheath, relationship to the vagal function, and of course we can provide a little bit of hyoid traction and tracheal release within the context of our nose and throat approach to treatment, drainage, etc. So again, for some people, this is not really new, but again, placing it within the context of the autonomic nervous system, placing it within the context of how we are addressing various components of various things, presenting symptoms that we have within the MS patient. So yeah, there's nothing new here. We're going to encourage excursion of the rib function, lung function, diaphragm function, and there's lots of modalities, lots of approaches that you can see here that can, facilitate that, all within the context of lever and fulcrum. And, this is kind of like encouraging various dynamics of the lymphatics ventrally in terms of the systemic chyli and the relationship with the right and thoracic ducts, which then continues with that lymphatic mechanism that's associated with the lymphatics in the head. So again, it's a very simple application of lever and fulcrum, but very valuable in our context. And this is all a component of treatment which I apply from time to time within the context of the treatment I give to this particular case study that we're looking at. And this is very valuable material, and it's done light and within the context of tissue compliance. We're not going to actually force anything upon the tissues themselves, but work within the parameters of the tissues themselves without forcing any particular aspects of our treatment. So again, nice, array of long lever on fulcrum application here that we're all familiar with. And again, we're thinking about our relationships of the specific autonomic ganglion. This is a nice picture taken from Caroline Stone's wonderful book, Science and the Art of Osteopathy. A wonderful illustration of how the respective structures that we can work with can be influenced again within the context of lever and fulcrum. And if you see to your right, so to the left there, you'll see some various aspects of treatment that we can utilize in terms of the upper thoracic and lower cervical dorsal region and the thoracic inlet and outlet relationships too, which all, can facilitate lung functionality. And again, this is one component that we want to encourage, is this whole gentle application of CD relationship to the stellate function and autonomic function of the inferior cervical ganglion and the respective autonomic pathways in the neck and the respective upper thoracic sympathetic chains that we deal with. So, this is, again, gentle application of treatment within the context of gentle mobilization without necessarily doing any specific adjustive techniques at this stage, if at all. So again, another parameter that we're dealing with is the GIT. This is becoming very, very fascinating in the context of how the immune system becomes involved at the GIT level in relationship to the autonomic function, specifically to the enteric nervous system. And the interesting thing is that once we begin to activate the enteric nervous system, the vagal afferent side of that picks it up and can quite often have a significant influence on the other mechanisms that involve with stress mediation, including the HPA axis too. So this is really interesting how we start to kind of like work within the context of providing some kind of enteric influence through our visceral approach and have quite a profound effect through both modifying autonomic function through the sympathetic and parasympathetic, and particularly the vagal aspect of the enteric nervous system too. So let's go into that in a little bit more detail in a moment. But our respective groups of structures that we're relating to are quite often the ventral plexi in relationship to the respective ganglion. So again, under our hands, within terms of our ventral work within the context of various components, various regions of the abdomen, we can begin to interface with these specific plexi, which have specific innervations to various blood vessels and specific viscera, of course. And we're doing that again for mechanico-transductive influence, but also, what we're working on a superficial level has a specific effect also on a deeper level too. And we're not excluding, the visceral aspect of general mobilization and improving motility function too. That quite often comes as a consequence of modifying the influence of the autonomic nervous system on the various aortic plexuses or various plexuses that innervate the blood vessels that supply the viscera too. So again, this is not high tech. This is just simplistic neurophysiology that we're discussing here. So again, we have these various mesenteric arteries, various branches that have rich anastomizing autonomic innervation. And again, we're dealing with those at a specific level in terms of the ventral plexuses or in terms of the associated ganglionic chains in relationship to the rib angles in relationship to various components of our treatment as well, including activity in relationship to the rib angles, rib heads, etc. So again, one component that we might provide influence on is the celiac ganglion, which has specific sub-branches that it innervates, and through gentle inhibition or pressure to that region infrasternally, we begin to have an involvement in terms of the sensory afferent aspects of the tissues around that area, but also in relationship to the celiac plexus. So again, we're providing this kind of like clockwise direction of movement, which kind of like facilitates a little bit of a pickup of mechanico-transductive influence upon those respective ganglion within that, the approximation to that celiac ganglion too. So again, this has got to be researched a little bit more, but a lot of the time we're within the context of my work, we're dealing with that kind of like relationship between Heads and Hilton's law, where we talk about the tissues on the superficial level influencing those on a deeper level, and the whole correlation of the perception of our digital interface being taken up by sensory afferents, conveyed to higher centers in the brain, and then producing a motoric effect as a consequence of that. So again, you know, when we start looking at that in terms of the enteric nervous system, it also becomes very interesting too. So we'll talk about that in a while. So again, we have other ways in which we can work with various components of the plexus. Again, hypogastric plexus being involved here, where we can provide again ventral digital pressure with gentle flexion of the knees to encourage relaxation of the ventral relationships of the viscera in the abdominal content, disengaging the psoas tension a little bit, and that provides us with the means of bear-defined graduated pressure, ventral pressure to the abdomen, providing visceral release, but at the same time engaging with the ramifications of these various plexi too. So inhibitory pressure, splanchnic response as a consequence of that, in terms of the ventral plexuses that innervates. And of course, we know degree of flexion together with depth and range. So again, it's a really nice application. We don't have to provide too much digging in with our fingers. We can provide the leverage through the limbs to provide gentle relaxation or release of the ventral structures, and get deeper interface with the structures, the visceral structures, and the ventral ramifications that the plexus that we're dealing with there. So again, this becomes fascinating because when we start looking at the effect of the neuroimmune interactions of the gut and the significance in intestinal immunity, we're quite often looking within the content of MS and other related conditions like inflammatory bowel disease, where there is a change in various components of the dynamics of the actual tissue lumen within the gut, and how that the actual marginal junctions of the gut are influenced by localized inflammatory responses. I'm just going to hopefully get this to zoom in. Go back to that one. I don't know why that didn't zoom in. It should have done. So basically, there's a kind of like significant influence from in relationship to the intestinal immune response, in relationship to inflammatory responses going on in terms of various components that are going on in terms of inflammatory mediation, which is quite often evoked by changes in the dynamics of the autonomic nervous system, but also in terms of the function of various trigger factors that are involved with the dynamics of the pH, but also the microbiome and the bacterial content within the gut too. So one of the things I wanted to show you here is the actual connection that we have between the what's called the cholinergic anti-inflammatory pathway that is involved with some mechanisms that we see typically within IBS, but also typically associated with prolonged systemic inflammatory, systemic autoimmune responses. There is a change in this balance between autonomic, the vagus nerve, and both the sympathetic splenic nerve becomes involved via the celiac ganglion, and that kind of has an influence on mediating inflammatory responses in various aspects of the gut. And this is something that is quite interesting when we look at the potential of change in autonomic tone in terms of sympathetic atonia or parasympathetic tone. And within the context of what we're trying to do, we're trying to influence that through the nature of our treatment. So we might be dealing with the vagal activity through, again, the relationship of its origin in the suboccipital region in terms of its nuclei, through to its pathway through to the carotid sheath, or in terms of stimulating its function through gentle visceral motility, mobilization in relationship to enteric function. But at the same time, we're trying to encourage, if there is an indication of change in the sympathetic tone, to influence that sympathetic effect local to the gut itself. So again, this involves various pathways. This is one of them where we have a particular relationship of either the vagal involvement or the relationship of the splenic nerve in terms of in relationship to the celiac ganglion, and of course the potential superior mesenteric ganglion being involved. So when we look at this mechanism in terms of inflammatory mediation in the autonomic nervous system, it's very interesting to see when we have these old ideas of providing inhibition to the solar plexus, what potentially we might be influencing in terms of these what's called the cholinergic inflammatory or anti-inflammatory pathways that are typically involved with autonomic inflammatory mediation of inflammation within the digestive system. So when you start looking at these studies, you begin to kind of like create connection between what we're doing and what is happening in the the more complex activity of the autonomic nervous system in terms of these specific inflammatory and anti-inflammatory pathways. So the sympathetic nervous system is thought to be actively involved in this anti-inflammatory pathway in synergy with the vagal nerve too. So it's not necessarily the case of this one is acting against the other. It's quite often it's a combination of both that are working in duality. And that's something that's quite interesting in terms of the mode of treatment that we give. So, for example, we're working, you can see there, the sacral outflow in relationship to sacral nerves. We look in terms of the thoracic, D5 to D9 in relation to the splenic nerves. We're relating to the ventral celiac ganglion and the superior mesenteric ganglion. And when you look back at a lot of the notes, Littlejohn, for example, on the treatment of gastritis, treatment of all these conditions, quite often there's this relationship to, dealing with the splanchnics, dealing with the mesenterics, dealing with the ventral portion of the celiac ganglion. And it all began, working with the basiocciput, working with the vagal function, and it begins to tie in with the literature that we read around this subject. So there's quite a nice way of providing this connectivity. So again, there are these particular neuroimmune interactions in the gut, and they have a specific effect on specific T cell responses, which and various other factors that are involved with inflammatory mediation. And if we look at here, mechanisms via which stimulation of the splenic nerve controls inflammation. Stimulation of the splenic nerve causes the release of norepinephrine, which binds with receptors on the colon acetylcholine chains, T cells. These cells produce acetylcholine, which reduces the production of inflammatory cytokines such as tumor necrosis factor, etc., etc. So this is the mechanism that's going on behind the functionality of splenic nerve stimulation. So when we start talking about splenic nerve function and how we can relate to it in terms of osteopathy, this is the very intricate mechanism that's going on, and it's really fascinating to think that we can have, or we need to research it more, but we can have this potential influence on this mechanism within the context of our work too. And again, another fascinating thing is that we have this whole idea that the actual sympathetic nerves, efferents, have a very close approximation to the actual lumen, the actual structures of the intestinal lumen. And they also begin to have an effect on the enteric nervous system too, in terms of actually changing mucosal layer and lumen functionality according to inflammation and inflammatory mediation. So, when we're talking about, hey, we're working with a sympathetic chain through this region, this region, and this region, and we're dealing with the ventral autonomic relationships of the mesenteric part of the ventral aspect of the autonomic nervous system, on the celiac ganglion or the hypogastric ganglion. These old texts where they say, you provide interdigital pressure, this is a mechanico-transductive effect which is beginning to interface with these particular structures that you see in front of you here. So, this becomes very interesting. And when we link it further, go further to depth, this is what's happening too. We have a respect to innovation of the actual crypts of the gut, innovating by neurotrophic innovation by the sympathetic nerves, involving, changes in the actual gap structures of the actual intestinal crypts themselves. So, when we have this leaky gut phenomenon, where we have this inflammatory response going on, there's a lot of mechanisms involved, and sympathetic function is, intricate in that role, as well as the enteric aspect of the nervous system in terms of the vagal side too. So this becomes really fascinating when you look at the actual mechanisms of inflammatory mediation in the gut, and how potentially we might have an influence on that within the context of our treatment. And that correlates to the MS patient too. So again, this is what we're looking for. We're looking at this mechanism where we have a change in the dynamics, and we have this cholinergic anti-inflammatory pathway, which we can begin to try to effectively influence through the modality of our treatment. And of course, you can see there with that other drawing, how the vagal tone influences intestinal immune homeostasis, tolerance or intolerance. And, this is excluding components which involve that, have an influence on that, which involves also the dynamics of the actual gut flora and the microbiomes too. So, when we treat the gut, we change modify the pH environment, perhaps that changes the colony of microbiomes within the gut too. So there's lots of parameters that we might have an influence upon, and they may not be aware of it at the time. But these are the mechanisms that we can interface with in terms of the autonomic nervous system. Okay, so for me, this becomes fascinating, specifically in relationship to the gut microbiome and the function it plays in terms of MS. And, what is the consequence of changes in gut flora, microbiome activity, and can we potentially influence that in terms of our treatments that we give? Well, if we go back to Little John's idea, I haven't got the slide here, I forgot to put it in. We have this idea that he presents called his equation, and that relates to a balance of detoxification or elimination within the body and assimilation. So, what are we doing within the context of our treatment? We're trying to provide assimilation by providing an ideal environment for those mucous membranes in the gut to absorb nutrients. We're looking at trying to eliminate toxins, trying to get rid of fecal material. So we're trying to encourage gut motility, reduce the potential for constipation. So all these components that we're dealing with within the context of our treatment, visceral treatment, can potentially have an influence on the dynamics of the whole gut microbiome scenario going on as well. So I'm just going to look at this. Oh, damn, that illustration's in front of it. It wasn't when I translated it. So I'm just going to stop the slide a second. I'm going to just make that go slightly different. I'm going to go back, forwards. Okay, this one can be front. No, sorry about that, everyone. Hopefully this will not get involved now. Here we go. So, a substantial increase in number of studies focused upon gut microbiome activity, autoimmunity, etc. And, you know, we're getting this scenario where the gut microbiome is defined in the summation of microbiome entities having an effect on gene structure, protein functionality, etc. And having a specific effect on, you know, facilitating pro-inflammatory cytokine response and inflammation. So, you know, some microbiomes are nice, some microbiomes are, you know, triggering this particular inflammatory response. So again, you know, if we can actually encourage good elimination in the gut, we can provide an ideal, you know, pH environment somehow. You know, we might have to evaluate that some way, somehow. But then we can kind of like have an effect on this component. And, you know, the whole idea of the microbiotic aspect of things is something that needs to be explored within the context of what we're doing within our work too. Can the nature of the microbiome environment change as a consequence of visceral intervention, for example, visceral osteopathic intervention, for example, not in isolation, but within the context of other parameters too. So again, you know, this is a nice example of this. Here's an example from the same paper where we have on the right, we have the dysbiotic microbiome, which is the microbiomes are not working in the general health of our body. It's creating pro-inflammatory mediators, creating inflammatory response. And then we're having a balanced gut pro-inflammatory response where there's immune homeostasis. And this whole, you know, inflammatory response is kind of like mediated through that autonomic interface too. So that's something we can kind of like work on indirectly in relationship to autonomic balance in one way or the other. But I just wanted to include this so you have an idea of what we're trying to do, and you know, the way in which these cells respond to various influences in terms of the microbiome environment, but also how the autonomic system kind of like picks this up and tries to mediate it over time in terms of neuroinflammatory responses that we have. So some of these materials will be on my resources for you to look at later. But again, you know, what are we doing within the context of our treatment? Well, you know, what I like to refer to is we're applying our visceral levers. We're applying our, you know, function of a gentle hands-on digital interface with respective leverage through our arms, through the legs of the patient, and providing ways in which we can kind of like provide general motility, drainage, and you know, facilitate elimination, but at the same time, assimilation. So again, going on, here we have various mechanisms of working with the viscera, again, providing release to the various flexures, various aspects of the ileocecal region, dealing with various portions of the ventral aspects of the small intestine, and working, you know, a little bit more superficially to deep according to the modality that we use, which we're all familiar with. But again, our idea within the context of our MS patient is to facilitate elimination, and that's what we're trying to do. Okay, again, something from Goetz years ago, working with, you know, action of the lower bowels. So, you know, this approach to treatment is not new. It's been around since the 1900s and before, most probably. Okay, let's continue because I want to make sure. Here we have again a mechanical transductive or mechanical influence on the autonomic, on the nervous system. As soon as we start to provide this particular visceral application in certain ways, we have an effect or mechanical-sensitive effect on the enteric ganglion, which respond by changing the actual functionality of the motility of the gut, but also in terms of the actual longitudinal and muscle wave functionality. So this is something I just wanted to throw in, and how the nature of the interface that we do within our visceral work is important, because if we're just digging in, quite frequently this is not going to have an effect on stimulating the mechanico-sensitive enteric neurons. But if we provide gentle, smooth, longitudinal application, this quite often facilitates the actual motility of the gut. So there's a lot of interesting research going on in terms of mechanico-transductive influence and how, you know, the nature of our treatment influences the efficiency of motility in the gut too. And again, another thing, you know, the whole activity of the serotonin function within the gut, which is again is significant in terms of irritable bowel and etc. Things like that, raised and changed, modified serotonin levels, you know, is again influenced by these kind of like mechanico-sensitive piezoelectric influences on the cellular level on the gut. So again, this becomes very interesting how the nature of our treatment has a potential influence on these particular functions of serotonin release, for example. So I just wanted to throw that in to show, you know, that this is significant work and has a significant influence, or we can have potentially significant influence on these mechanisms. So again, one thing we have to consider is when we're dealing with the MS patient, is quite often we get the scenario where we get changes in pelvic floor function, tone of the pelvic floor, and we actually get this scenario where we have changes in sphincter function. So we can begin, as you see here, be demonstrating various components where we can dealing with working with various structures within the pelvic floor, providing inhibition. And as you see here, I'm beginning to engage, or was beginning to engage, the sacrum in relationship to the ilium, providing a little bit of a gapping and facilitating the sacral functionality, prudental nerves, etc., that we're dealing with. So this is something that we can do and facilitate the function of the pelvic floor and also the function of actual defecation. So we don't get this kind of like impaction and obviously restrictive constipation that we have. Okay, so I'm going to go on from here. Again, you know, there's other modalities. We've got to consider the fact that quite often when there are changes in motoric function, we get changes in the actual autonomic balance within the function of micturition. And we get what's called a neurogenic bladder presenting, and we get changes in the actual pathways, but we can actually have a gentle influence or potential gentle influence through our ventral work on the bladder and begin to influence the bladder function itself in terms of the elasticity of the bladder a little bit, and also if we can to stimulate more voiding of the bladder through just providing more dynamic flexibility within the bladder itself. So there are certain aspects of working with the bladder in terms of its suspensory structures and adjacent viscera too. So again, I'm running through this at speed, but I'm just going to keep an eye on the time. So this is one aspect that we're dealing with. We're dealing with the suspensory structures here. Again, a wonderful image from Caroline Stone's book showing these structures that we're dealing with. And the modality is again using the lever of our hand, arm into the various suspensory structures and providing a little bit of release if we can, visceral lifting, but also within that context of bringing the knees up, providing more ventral relaxation and again release within the suspensory structures there. So, you know, this is not a kind of like A to B of how to do it. This is just working within certain parameters, certain viscera, certain components of the symptom patterns that we're having, and how we can kind of potentially facilitate you know, functionality there, again, if we can. So again, there. And now we go on to various other aspects of it, the neuromuscular rehabilitatory side of things. And of course, you know, we're getting these scenarios where we're getting fatigue, limb weakness, we're getting spasticity, atrophy, we're getting foot drop, we're getting kind of like a dysarthria, certain kind of things like that going on. So, you know, we can work to some degree with that. And I just wanted to introduce this kind of like model that I picked up from L. Lederman, where he looks at the whole dynamic of looking at it as rehabilitation rather than rehabilitation, where we're looking at actually trying to reactivate muscle groups around the specific associative limb structures. So again, if you see this, we're looking within the environment of the actual person, of the movement of the particular limb. We're trying to create both synergetic and parametric abilities to encourage movement and to try and encourage, if we can, do strength over time in terms of duration and ability. So all the methods of rehabilitation I'm working with are focused on the patient developing their own motivational based exercises. I'm not giving them task based exercises. I like to involve my patients with, dealing with exercise modalities which they can do from day to day according to their abilities. So we actually have a schema which is almost, well, it has actually been formulated on an individual basis according to the way they're feeling, according to their abilities in terms of the timeline during their weeks or months or days, and being able to adapt to those accordingly. And that seems to be quite successful at the moment, because it encourages a kind of like constant exercise parameters without actually putting too much stress or strain or fatigue on the patient themselves, because they're working with the parameters that they're familiar with and developing an exercise which is based on this mechanism according to what they can do and what they enjoy doing. So that's become very positive in terms of that aspect too. So again, if we look at this one, this is something that my patient case study has been working with, just a simple movement around the dynamics of kicking and flexion and extension, with, of course, the assistance of balance with her perambulation device there. But again, giving her motivation and working on various things with music, with movement, and in conjunction with other things too, including yoga, breathing exercises, and within the context of her ability and, motivation. So let's continue. What is the nature of the interface? Well, we're working with various parameters of various aspects of our work in terms of the nature of the function of the posterior or dorsal rami in terms of the tissues on the back of the spine. And we're also dealing with both the, interoceptive, the feeling of the patient too, in terms of the sensation of well-being and ability, but also the homeostatic aspect of the body. So, once we start dealing with all the other systems, we're addressing the homeostatic aspect of the patient too, which deals with this interoceptive phenomenon, as well as the exterior environmental, exterior receptive aspect of the health too. So this becomes very interesting when we look at this in terms of what we can do in terms of the nature of facilitating that. Of course, interoceptive in terms of homeostasis. We can do the visceral work. We can do a whole lot of components of our work in the context of the autonomic nervous system. But in terms of how we can influence the exteroceptive influences by the nature of our treatment. Is it calming? Is it stimulatory? Is it inhibitory, etc.? And that's very valuable, and that's something that comes in. And you can see here the complexity of the parameters of the nerves that are involved just purely within the domain of that dorsal rami relationships. So the base of the neck, all the way through to the head, beyond down to the sacrum, through the spine. So again, when we're dealing with our treatment, specifically in relationship to spinal oscillation, mobilization, we're dealing both also with other parameters, venous, arterial, and of course CSF. So that's another modality that we're dealing with. So there's a continuum of various systems that we're dealing with here. And quite often, we're dealing with that whole idea of where we can change the artery dynamics, venous decongestion. Once we start to facilitate decongestion in the spinal column, we can facilitate CSF functionality. We can change the dynamics of the suspensory and dentricular ligaments in the actual spinal column too, facilitating that CSF flow as well, etc., etc. So again, we're actually dealing with the consequences of prolonged stress, the influence of the condition on the patient. And we're also dealing with the whole emotional aspect of things too. So when we're dealing with this, we're dealing with the fact that, you know, the body's adapting quite often to this change in influence of the HPA axis, influence the autonomic balance, the neuroendocrine influences too. And, you know, just by the nature of our treatment, we can kind of like facilitate, you know, a little bit more relaxation, a little more calming. And quite often the oscillatory dynamic of our work is very significant too, especially when it's accompanied by our inhibition that we give. So again, we have all these various specialized nerve receptors in the skin that we're perceiving the nature of our touch. And the nature of our touch has a significant influence on the perception and feeling of security, but also, you know, the perception of the nature of the self, in terms of, you know, if we give a treatment that's too aggressive, then that is considered to be a threat. But quite calm, influencing spinal inhibition, providing oscillation, is quite smoothing and has quite a profound effect on the perception of well-being too. It influences that over a certain amount of time anyway. So, you know, the dynamics of serotonin, cortisol, dopamine, influenced again by the nature of the application of our treatment. So that's again a very significant thing to consider, especially when we're dealing with MS patients. So again, mechanotransductive effect that we're having through our nature of our digital interface is having an effect on the intracellular matrices, having an influence on actual, you know, physiological influence on our body, on the patient's body too. And, you know, this is dealing with gentle torsion movement, gentle shearing movement, the E's and T's of tissues, responses to tissues, as well as we're working with, again, the context of our oscillation, for example. So let's start with treatment outcome. One of the things that we had difficulty with the dynamics of MS is that, you know, the outcome is very different. Measure is variable, and you know, one patient is always the same. That's uniform with everything, but typically in this condition, this scenario, it's something that we have to consider. You know, the challenges compound when working with people with multiple sclerosis owing to the heterogeneity of the patient population and symptom variability in individual patients. Well, that really ties in with our philosophy in osteopathy. You know, we work with the individual patient, and, you know, the dynamics of our treatment reflects that too. So here we have it. We have, you know, a lot of outcome measures that we can tap into to see how the efficiency of our treatment is going. This comes from the Multiple Sclerosis Outcome Measure Task Force, and one of the things we started to look at was just very simple, kind of like movement tests, 2-minute walk test, 5-minute sit down, standing test. But when I tried this just as kind of like a little pilot with my patient, she wasn't too keen on the actual aspect of doing this over and over and over again. She didn't see it as a very motivational based exercise, saw more of a task based, and after a while got rather reluctant to do this. So time is running out, but we'll continue. So, you know, we started looking at different things, including developing her own motivational based exercises, which gave her various components involved with that. So again, another thing I've included with another 2 or 3 patients of mine is actually developing, you know, one aspect of digestive measurement, and that's our, you know, standardized Bristol stool chart. And I've got actually 3 patients that are actively busy giving me data relating to that at the moment, in a rather constructive way. We haven't looked at it in terms of just purely the, you know, the nature of the numbers, but actually how they can potentially influence the nature of the numbers through modifying their diet and certain activities. So yeah, I'll talk about that at a later date when I do a bit more research on this, but it's very interesting once you get the motivation behind what's going on with their treatment, they turn this into quite a dynamic game between themselves. And this is what we've done actually. And you know, they see this quite often as a quite a humorous aspect of their lifestyle at the moment, is to actually look at their stool function, but at the same time looking at it in terms of how they can influence it too through their diet and activities. So they're really kind of like focused on that, but in a different context rather than just purely an outcome measure. So that's become interesting with the 2 or 3 patients I'm working with at the moment. And again, gait variability is one of the things that's very significant. And within my case study, I've been busy with that, with using combination of motion sensors and Internet of Things to actually facilitate some kind of like analysis of movement, device-assisted exercise using the parameter there, but also motivational based. So effectively, we have a sequence of exercises that is done, and through the parameters that are shown on a particular dashboard that I have access to through my server, and my patient also can see from time to time if she wants to. She can actually look at the kind of like daily parameters that are going on, and now I'm beginning to implement what's called machine learning to look for specific kind of like patterns within that too. And what's nice is that this kind of like gives good feedback as well in terms of just showing how, you know, various modified exercises, motivated exercises, give a constant result of good outcome in terms of ability according to the nature of how they feel. So they don't see it as a kind of like a marker of, oh, I've done good or bad, but a marker of continuity of ability. So that, you know, changes their kind of like mindset towards exercise and towards rehabilitation, their own rehabilitation as well, which again is, you know, facilitated through hopefully through my intervention within our treatment. And this is something, again, another outcome measure that we're looking at over time, and hopefully will become a longitudinal study. So this is something that she's also developed herself, again, dealing with balancing simple exercise ball in the ankles and the knees, working with various degrees of gross and fine motor activity. And this is something she picked up and developed herself. And we're using now and implement those sensors to see how that is going over time as well. So again, you know, this is turning that scenario of going from the label of having a condition or whatever to a component to become proactive in their health as well. So I'm really excited by the parameters and the potential of this in conjunction with our treatment in the near future. And again, you know, there's various interesting things that are coming up in terms of research, in terms of proprioception. You'll have access to this. But, you know, within the context of the body adjustment, we're using passive range of motion within proprioception. And this is interesting because, you know, there's indications that we're having an influence on the cortex, primary motor cortex, through that mechanism. So, you know, it's nice to see these papers to some degree. I'm not cherry picking them, just being aware of them. This is something Nigel Jones sent to me, fortunately, so I'm very grateful for him to sending me that. Looking at behind the mechanisms that are involved with our application of osteopathy. So this is one mechanism that's very interesting. I'm going on to research that's been done. So there's quite a few MS research already done in the context of osteopathy so far. There's been various people involved with various components of, you know, regional influence through cranial influences through various components of the digestive system as too, using the GIT parameters that I mentioned before, and also Michael Shakura with his colleagues started looking at the dynamics of exercise, and particularly how when you use this modality of maximal effort within exercise, how you can actually facilitate motor strength and actually kind of like create like a resistance training mechanism and a strength training mechanism to facilitate muscular motoric and muscular strengthening over time. So no, this is very interesting that the paper's available to look at. But again, another parameter that's already been researched with comparatively good outcome. Again, another one where there's been looking at manual treatment in multiple sclerosis, proof concept study, Indonesia, and looking at various modalities, again with very specific outcome measures that you'll see there, and utilizing various treatment approaches within the context of the cranium, within the context of adjustments, and looking at that over time and how it changes the parameters of these particular outcome measures. For example, clinical disability, quality of life, depression, fatigue, and anxiety, and extended disability status scale, which seems to be like the gold standard for MS evaluation anyway. So the outcome for that was that their scores improved to some degree, and it demonstrated the potential of MS patients with chronic symptoms and the influence of osteopathic intervention too. And then, of course, we have this one recently, well, not too recently, which was where there was a group of osteopaths from America, GOA, were involved with developing a particular protocol which involved the thoracic inlet, involved myofascial releasing, and the sacral dynamics to change the potential vagal function or the parasympathetic tone. So again, tying in with the autonomic influence on potential on the systemic influence of the parasympathetics as well. Again, that also ties into the inflammatory responses, etc., that we talked about. Okay, there's two of those. So other things to consider. This will just go over and over again. I've almost come to an end now. I'm just going on for a little bit while, but hopefully this is kind of like giving you a kind of like an insight into different parameters that we can start looking into and addressing within the context of our work, and most importantly, addressing this scenario within the context of body unity, so that we're looking at dealing with the neuromuscular aspect of things, we're dealing with autonomic immunity, we're dealing with digestive, we're dealing with visceral, we're dealing with cranial, we're dealing with lymphatic, vascular, venous, etc., etc. And we're beginning to look at this, and a lot of these things that we're looking at here that are flying before you are also parameters that we've got to address. And these are things I'm looking into addressing also, is cognitive function, the nature of pain perception, the effect of balance, posture, coordination, and the way in which we can influence potentially the plasticity, the neuroplasticity within the brain, but also in terms of the actual the autonomic nervous system as well. So anyway, that's the end. Hopefully you've not been overwhelmed with my speed, but hopefully you kind of like part two has brought a little bit more into the neuroscience behind it. And also, the nature of the interface, the nature of our work, and how we can specifically work within the context of the autonomic nervous system, and how that is kind of like being endorsed by a lot of materials and papers that are out there that are kind of like indicating the potential of the mechanisms behind our work that again need to be researched a bit more, but give a parallel and give a good bit of an explanation as to the neuroendocrine and neuroimmune mechanisms that we might be working with and addressing within the content of our work as osteos. Okay, so that's it. If there's any questions out there, very open to any questions and answers if there are any.
Thank you, Tim. That was very nice, going through all the aspects of the treatment, and I think especially those techniques that you were talking about, from the eyes to drainage of the head, the gut, the bladder, the constipation. I think it was very good format. Thank you. I was going to ask you, do you do any nutrition advice as well?
Yes, that's definitely something that we look into, and it's dealing with basically various components where we are encouraging, most importantly, to begin with, if we can do the drainage of the gut itself to try to facilitate or reduce constipation. But we're also looking at, various essential nutrients that are easily taken in by the body too. And I know there are specific diets that relate to MS, and I'm not a nutritionist. So quite frequently I will talk to other people that have experience in that field. And then, we go through a food log of sorts with the patients. And then that's, that my work is facilitated by a nutritionist. I'm not a nutritionist. I have an understanding of some aspects of, visceral function and, the essence of essential nutrients that we need for the body to do what it does. And the funny thing is, of course, liver function is very vital to what's going on. And, the thing is, liver function doesn't, detoxification and all these other things don't work if we don't get the right nutrients to supply the conjugation process of the liver. So, that's another thing. And another thing is, we can't get the patient to assimilate whatever they're trying to do to eat unless we eliminate. So, my main key function, my main focus for all my patients is let's get that motility of the gut working. Let's get that elimination processes for the skin, the bladder, whatever we need. Detoxification is the key. And then once that process begins to kick in a little bit more, assimilation becomes much easier. I know it sounds very, very basic, but when you look at the complexity of Little John's equation and all the complexities involved with just liver function in terms of assimilation and oxidants and all these kind of things, it's very complex. So I don't, I will, the nutritional aspect of that, I always do it in consultation with someone who's in that field.
I understand.
Once we start getting the constipation value stabilized, which is why I use that kind of like Bristol stool chart scenario, then we can see the changes in the body's, the patient's ability to take in the nutrients that they're having, and over time.
I just had a patient just a couple of weeks ago, and she's in a very early stage of MS, and she went to Madrid to visit one of the main doctors or most experienced in Spain. And he said what they have to do is exercise as much as they can, every day they can. Not just gentle exercise, but brisk
it can be
walking.
pretty dynamic.
Yeah,
the trouble is you've got to be careful of the fatigue aspect of that.
Yes, exactly. That's what he was saying.
Yeah.
Exactly.
So this is why I've been working with this kind of like Internet of Things with one or two of these patients now, where I can get daily analysis of their exercise parameters, and we can look at the fatigue parameters associated with the duration of exercise. And I'm getting them involved with developing their own exercise according to ability on that specific day. So they can still do their exercise on a daily basis, but according to their ability. And that is involved them with that. And they become very proactive with that. And every time I see them, they're quite often saying, "Oh, I've developed something new for when I have this particular moment. When I've got spasm in my legs, but I still want to do upper torso exercise, I should do that. If I've got this, then I do that." So, they're continuing, but according to, parameters that allow them not to become exhausted. So that's nice. And, that's something I'm working with. So my ultimate component of this will be to do a longitudinal study where we apply, the treatment approach, multi-systems, which is essentially body adjustment, within the context of the patients on an individual basis, of course, but then look at these parameters. And we can, if we want to, break them up into various systems, but at the same time, get the data collated so that patient has, and that group has a specific outcome measure that gives a little bit of evidence that we're getting somewhere with the treatment, and can endorse what we're doing within the work of osteopathy. Definitely. So that's what I'm planning to do over time. So the last slide here, I'll give the link to this in about a week when it's finished. There'll be my slides, and there'll be access to links to various documents that are included within the presentation.
I will be editing this video for everybody to watch in Vimeo again.
Yeah.
And thank you, Tim.
No, it's a pleasure.
Just after watching today, I would like to offer you one day, maybe doing a practical one-day workshop or something like that.
This is settled.
That would be nice.
The workshop comes with it. I've done it a little bit with some other colleagues that are associated with the Institute. And it's something that's very valuable. And, my aim would be to be in a situation in about 3 years' time where I've done my longitudinal study, I've got some results, and I can say, here is not necessarily a rationale because we're all using it, but, let's see whether we can get some more outcome measures on a more international level, and, see whether we can get this endorsed as an approach, towards those others that are involved with MS.
Totally agree.
Valuable. I've enjoyed the whole process of discovering this, and it's, as I say, the materials at different levels. I have a certain level of understanding and implementation of this, and I'm still learning, and it's a wonderful process, and it's lovely to share it with people too.
Okay. Fantastic. So thank you very much.
You're very welcome, everybody.
Thank you, everybody, for connecting to this webinar. I hope to see you in next one in January, or maybe in the conference with Tim and.
Well, I'm looking forward to that. That's going to be a very interesting one. We're going to revisit the nature of the body adjustment in terms of the spine. It's going to be fun. It's going to be fun.
Very good. Thank you.
Okay. Thanks very much indeed, everybody.
Thank you very much.
Take care.
Have a nice Christmas time.
And you and everybody out there.
Okay.
And, take care of yourselves. Okay.
Take care.
Thanks very much. Okay. Bye. Bye.
Bye. Bye.